Well, I'd like to welcome you all to the third annual University of Michigan Multiple Sclerosis Center Patient and Caregiver Conference. I came to Ann Arbor 5 years ago, and at that time there was only one MS specialist seeing patients, and he was doing so part-time, and there was no laboratory devoted to MS research. Now, 5 years later, we have 4 MS specialists who are caring for patients in our clinic, which is composed of approximately 2,500 patients and still growing. We started a new MS specialty clinic at the VA hospital down the road, which has several hundred patients. And we have 4 laboratories devoted to MS research, which are populated by young students and fellows devoted to increasing our understanding of MS and leading the way in the development of new treatments. So it's been a very encouraging experience, and none of this would have been possible without a certain family that I've acknowledged in past years, and I'd like to do so again. This is Marilyn Holtom Garrett. She battled with multiple sclerosis for 25 years before her death in 1991. By all accounts, she did so with courage and dignity. And her family started a fund to establish a new MS research center at the University of Michigan. Marilyn Garrett's father was a physician who trained here. Marilyn was also an alumna, as was her mother. And her father started the fund, but then it was expanded by her husband, Richard Garrett, shown here with his second wife, Marjorie. They endowed a professorship that led to my recruitment and everything that followed. Marilyn and Richard Garrett had 3 children, and they've all been active in the center. Marcia, Richard, and David. And David and his wife, Donna, have been very generous in continuing the contributions of the family to strengthen our center and to expand it. This is the Garretts when the professorship was inaugurated. And here's the entire Garrett family, and I'm pleased to say that David Garrett and his wife Donna are here with us today. Here's David, his wife, and their children also attended. So this is a summary of what the MS Center looks like now. As I said before, we have 4 physicians. We have our wonderful nurse, Kathy Bennett. I'm going to make some remarks about Kathy a bit later on. We have a nurse specialist at the VA, Lindy, and we're in the process of recruiting a nurse practitioner. We also are looking into recruiting yet another multiple sclerosis specialist as the demand for appointments remains high. We have started a clinical trial program in which new drugs are being investigated, the next generation. We have a clinical trial coordination team that is now largely spearheaded by Dr. Tiffany Bradley and Judy Rothoff, who also has joined us today. And we have a list of scientists and fellows and students all working very hard to better understand the disease and lead the fight towards a cure. And we hope that all the different activities speak to one another and that we can learn from our patients as we treat them. We could offer new drugs in the context of clinical trials and clinical studies to better understand the disease. And then we bring some of the information back to the laboratory in which we study blood cells from patients with MS. We have studies in MRI technology, and we also use an animal model of multiple sclerosis-like disease in order to make future advances. So this is the agenda for today. Following my opening remarks, Dr. Tiffany Bradley, an associate professor, is going to speak on new and emerging therapies for the treatment of multiple sclerosis. Then Dr. David Irani will discuss nutrition in multiple sclerosis. And then our newest doctor, Yang Mao Dreyer, will discuss progressive multiple sclerosis. And then that'll be followed by a few remarks from myself about the research that's going on here and elsewhere. And finally, from noon to 1, we will have a roundtable discussion in which we will answer questions. I believe that forms and pencils will be handed out so you could write down questions that we will all discuss sitting at the table to my right. So without further ado, I'm going to ask Dr. Braley to come up. Okay, I think we were able to work this out. Okay?
Okay.
Dr. Bradley, who is a young rising star in the MS world, and she's spearheading our clinical trial program, and she's going to demonstrate those skills and eloquence right now.
Thank you. So I just want to take this opportunity to thank everybody for coming. It's nice to see such a large crowd, especially on a Saturday in the middle of summer. I see a lot of familiar faces, so welcome. Those of you who, I think a lot of you know me, but I'm Tiffany Braley, and I'm going to try to give you some new updates today on the new and emerging therapies in multiple sclerosis. Any of you who were here last year might remember that I gave a similar talk, but I have some updates for you on a few drugs that I'd like to discuss today. So just to give you a sense of what we're going to be talking about this morning, I'm going to spend some time first talking about a recently approved MS treatment for multiple sclerosis. Many of you may have heard about this medication. It's called fingolimod or Gilenya. And after that, I'm going to talk about some new emerging, very promising treatments that are being studied right now in multiple sclerosis that I think may have a future in the field of MS. And those are a drug called alemtuzumab. The trade name is now Lemtrada. Another drug called ocrelizumab, which is being studied in clinical trials. And finally, another oral medication that looks promising called BG12. So if you were here last year, you may remember that I also showed this slide last year, but I like to show it because I think it reminds us all just how far we've come in terms of multiple sclerosis treatment over the last few years. It may be hard to believe, but it wasn't that long ago that we had few, if any, effective medications for multiple sclerosis. You can see here, I'm going to try to, okay, you guys see that laser pointer? As early as the 1970s, we really didn't have much of anything. We had a few treatments here, steroids, a drug called ACTH, and another drug called Cytoxan, and some of you may still recognize these because they are still occasionally used. But these drugs aren't very good in terms of long-term therapy, and the medications that we used to have weren't very effective for long-term treatment, or they had side effects that prevented them from being used in the long term. And as you can see, as we go through here, we don't really have a lot going on in the 1980s, the early 1990s. Really wasn't until the mid-1990s, early 2000s, where we started to see a few more treatments become available in the form of those injectable treatments, so Copaxone, and also the beta interferons, which many of you may be using now. And eventually Tysabri in 2006. But look here at 2010 and beyond, and you can see that based on advances that we've made in terms of understanding the disease, we have been able to develop a lot more promising treatments for multiple sclerosis. This is not a comprehensive list. There are others, and I won't be able to focus on all of these today. I'm going to tell you about the ones that are furthest along in this pathway. But this just gives you an idea of how many more options that are possible for us in the near future. So before I start talking about the medications, one other thing I'd like to do is just sort of orient everybody to the concept of clinical trials. When we talk about MS therapies, especially new ones, and when you hear about these things in the news, you often hear a headline on the news that says, well, phase 3 clinical trial showed that this MS drug did this, or a phase 2 study showed that this new medication did this. Well, what does that really mean? Well, the bottom line is that before a drug can come to the market for human use, it has to go through 3 phases of testing. And the first phase is called phase 1 testing, phase 1 clinical trials. And that is primarily just to see if the drug is safe enough to use in humans. Often this involves a population of patients that don't even have the disease. These are often tested in healthy volunteers. And if the drug looks like it's safe for human use and they find a safe dose, then it goes on to what we call phase 2 studies or phase 2 clinical trials. Now, phase 2 clinical trials are the first real test to see if the drug is actually working for the disease, if the drug is doing what you want it to do. And in the case of multiple sclerosis, this often involves testing it in terms of the patient's, seeing if it controls the patient's relapses, but also how it affects the MRI findings. And then finally, if it passes the first test and it looks like the drug is effective in phase 2 trials, then the drug is given to a larger population of patients to confirm that it really is effective and also to do additional tests on safety. And those are the phase 3 clinical trials that you read about. They have to get through phase 3 before we can consider FDA approval. So once they've gone through phase 3, that's kind of the final step. But before we go on, I just want everybody to remember that whenever you're looking at a new medication, whenever you're trying to decide if a new med might be right for you, there are 4 points that should always be going through your mind. First of all, you have to know what the drug is expected to do. What should it be doing for your disease? We often see a lot of times with MS medications that patients say, well, I'm taking it, but I don't feel any different on it. I don't feel better. And actually, that's often the case. These MS drugs that we use are often used to prevent new problems, but they're not necessarily going to treat the problems that you already have or make you feel better in the short term. But it's important to know that going in so that you have realistic expectations about what the drug can do for you. It's also important to know, is the medication effective for your type of MS and for the not only the kind of MS you have, but the aggressiveness of your MS, and this is an important discussion to have with your doctor. And then, of course, not to forget, do the benefits of the MS medication that you're considering outweigh the risks? A lot of times patients have other medical conditions or take other medications, and it's important to decide if the medication that you're thinking about starting is going to interact with anything else that you're taking, if you're going to have other problems because of other medical conditions you might have. All of these things have to be weighed and taken into consideration. And then finally, can you manage this medication for the long term? As you probably know, most of these medications are meant for the long haul, and we do know that the patients who are able to pick a treatment plan and stick with it usually do the best. So fingolimod is a new medication that's been out now for about 2 years. This is an oral drug for relapsing multiple sclerosis, and it was initially FDA approved in September of 2010 as the first oral MS therapy. And the goal of this treatment is it's used to reduce the frequency of clinical relapses. And when we use the word relapses, we mean flare-ups, we mean exacerbations, MS attacks, those all mean the same thing. And also to delay the progression of the physical symptoms of multiple sclerosis. And this drug works in sort of a unique way. It actually traps immune cells, the immune cells that are thought to cause MS. It traps them in the lymph nodes so that they can't get out and go into the central nervous system and cause damage. It's once a day dosing, which is attractive for patients. And it is fairly effective. There were 2 main clinical trials that led to this drug's approval. The biggest one was called a trial called the Freedoms trial, and this was one of those phase 3 studies that I was just mentioning earlier, where they took a look at 2 different doses of fingolimod and they compared it to placebo to see how well it worked at controlling patients' relapses and also improving their MRI outcomes. And it turned out that the fingolimod was able to reduce about half of the number of relapses in MS patients, so about a 50% reduction in terms of new relapses compared to placebo. And it also did have some benefits on the MRI. Fewer new lesions were seen in the patients who got fingolimod than the patients who got placebo, so that was good. And it also did prolong the time to disability progression. So there was another study, a smaller study called Transforms, which was only a year long, that also compared fingolimod to another drug that's already available for treatment called Avonex, which is a beta interferon. And it also looked like the fingolimod was superior to Avonex in terms of reducing the number of relapses patients have and the number of MRI lesions that formed. So in terms of safety, this drug was effective, but there were some initial safety concerns in the clinical trials that I just mentioned to you. A couple of the side effects that were seen in patients was slowing or a blockage of the heart rate, so slowing down of your heart rate. There were a few rare extra tumors and cancers in the fingolimod group compared to the placebo group. The fingolimod was shown to decrease your white blood cell counts in some patients. Another medical problem that was noted is something called macular edema, or a swelling of the macula, which is a part of the back of the eye. And finally, in the smaller trial, the TRANSFORM study that I showed you, there were 2 serious infections involving an infection of the brain with the herpes virus in one case called herpes encephalitis, and another case of something called disseminated varicella zoster, which is the virus that causes chickenpox. But nonetheless, because of the effectiveness of the drug and because the FDA felt that the safety profile was still reasonable, it was FDA approved in September of 2010. And at the time, when the drug first became available, there was some monitoring that was recommended based on the risks and side effects that I just showed you. But these were more, I'd say, recommendations and guidelines as opposed to requirements to starting the drug. Both the FDA and the makers of Gilenya did recommend that patients receive their first oral dose in the clinic and then be monitored for 6 hours after they receive their first dose, simply because of the side effects that I showed you regarding the heart. So it was shown in the clinical trials that if patients were going to have a slowing of their heart rate, it was usually going to happen within the first 6 hours of treatment. And they also gave some cautionary guidelines if patients had any other heart problems, liver problems, high blood pressure, or if they had a history of diabetes or other treatments that affect the immune system because of potential infection risk. And that's pretty much where I left off with my discussion of Gilenya last year. But fast forward to the fall of 2011. In November of 2011, there was a patient who took Gilenya, and a day after this patient took Gilenya, they died of sudden cardiac death. So based on this person's death, this was a 58-year-old person who was taking a few other medications that could slow down the heart rate, so that's important to know, and may have had some other medical conditions. But based on this, it did raise some concerns about the safety profile of Gilenya. And so the FDA decided to go back and review some of the cases involving heart problems and deaths associated with Gilenya through the clinical trials, and also through other patients that had already started the medication. By the time this person had their event, the United States had already been prescribing Gilenya for quite some time, so there were quite a few cases to review. Based on the review, they decided that it was still okay to keep it on the market, and it is still being prescribed. But now there are some new safety guidelines in place, and some additional warning on the labeling that patients need to be aware of if they're considering taking this drug. So these are the new FDA recommendations, and this is the update that I wanted to make sure everybody had today. Of course, the 6-hour observation period in a clinical setting is still required, so anybody who's thinking about it still has to have their first dose in the clinic and be monitored for 6 hours. But it's also recommended that patients now undergo an EKG, not only before they receive the drug, but also after that 6-hour period in the medical office, to make sure that there haven't been any significant changes in the heart rate or the heart rhythm. And then it's also recommended that patients who are being seen for that 6 hours have their blood pressure and their heart rate checked every hour for that full 6-hour time. And now, as opposed to guidelines, the FDA has listed some contraindications. Now, contraindications are basically reasons that you should not take the drug. And they have listed the following as potential reasons for not taking the drug: heart attack or stroke within the last 6 months prior to starting treatment with Gilenya. Second and third degree heart block would also be reasons that you wouldn't be a good candidate for this medication if you had a history of heart block. Or any other heart rhythm disturbances where the heart wasn't pumping appropriately, or didn't have a normal rhythm. And also those taking medications that control the heart rhythm, called antiarrhythmic medications. So the medication is still available, but it is important going back to those 4 questions that I gave you earlier to ask yourself, is this medication safe for you? Is it safe for you in the context of all of your other medical problems? I think that there's still some things to be learned about this drug, and we'll keep you informed as we hear more about that. So now I'm going to switch topics and talk about a new drug that's being tested for multiple sclerosis. It's called ocrelizumab. This is a new drug that's given IV, so intravenously. And one of the attractive features about this drug, it only has to be given every 6 months, so it doesn't have to be dosed very frequently. This drug is similar to another medication called rituximab. I don't know if any of you have heard of rituximab. Rituximab has been out for quite a while for other types of autoimmune diseases, and it actually has also been studied in MS itself and has shown some promise. But ocrelizumab, which is very similar, seems to have a better side effect profile than rituximab does, and that's why this is the drug that is now being studied more rigorously in multiple sclerosis. So there are other clinical trials going on for ocrelizumab, both in MS and other autoimmune diseases like rheumatoid arthritis. So I just wanted to give you some information about what we think ocrelizumab can do in terms of its effectiveness. One of the phase 2 studies for ocrelizumab has already been published. This was a study that looked at ocrelizumab treatment in patients with relapsing remitting MS, and these patients had monthly MRIs and clinical exams, so they had quite a few MRIs during this study. And the effects of ocrelizumab were compared to a couple of different comparators. So it was ocrelizumab compared to placebo, and some of the patients also got interferon treatment to see if the ocrelizumab was also more effective than the interferon. And it turned out that the people that got ocrelizumab did substantially better in terms of their MRI findings over that study period. Very few lesions were, substantial reductions in the number of lesions that formed during the trial itself while patients were getting the ocrelizumab. And this drug beat both the placebo and the interferon patients in terms of improving the MRIs. Also, it's important to note that 2/3 of the patients that were initially treated with ocrelizumab were still completely relapse-free at the end of the study. So not only did it reduce the number of relapses in general that the patients had, but there were still many patients who never even relapsed during the study when they got the ocrelizumab. So because of the success of the phase 2 studies, they're now going on to phase 3. And I'm pleased to say that we have 3 multi-center studies that are ongoing over the world. Many of these are being done and tested. These studies are being tested at sites across the United States. 2 of these studies are for relapsing multiple sclerosis. These are called the OPERA studies, if anyone's interested or have read about it, OPERA 1 and OPERA 2, and they're essentially identical studies. And then there's another study that's being done right now for primary progressive MS, which is very promising. One of the OPERA studies, we're actually beginning that at the University of Michigan very soon, so we are starting recruitment. And the study it involves being treated for 96 weeks and studied for 96 weeks. And patients are either going to get the ocrelizumab, which I just mentioned, or Rebif. So it is being compared to Rebif. And you have a 50-50 chance of getting one of these drugs. Nobody really knows what they're going to get. It's all random. But the effects of the drugs are going to be studied in terms of both looking at relapses and also looking at the MRI outcomes similar to the phase 2 studies. And I should mention that the study is double-blind, which means neither the study team nor the patient will know which medication they're getting. And you may say, well, Rebif's injectable and ocrelizumab is IV. I think I'm going to know the difference, right? Well, actually, they're going to do this in an interesting way where they blind you by giving you one drug, which is placebo, and the other drug, which is real, which means any patient who goes into this study is going to get an IV treatment and a treatment that they inject 3 times a week. And you won't know if you're getting the real ocrelizumab and the placebo Rebif or the real Rebif and the placebo ocrelizumab. But then we follow the patients very closely with physical exams and MRIs. So if anybody is interested in the OPERA study, these are the basic criteria that you have to meet. There are others, but we could always talk about that separately. But the main criteria are that you have a confirmed diagnosis of relapsing multiple sclerosis, at least 2 clinical attacks or relapses in the last 2 years, or 1 clinical attack in the last year prior to being screened for the trial. And also that you have an MRI that's consistent with multiple sclerosis. We want to make sure that everybody is properly diagnosed before we enroll. But if you meet these criteria and you think you might be interested, I've put our clinical trials office phone number on the screen here. I think we probably also have this information in the folders, I would imagine. If not, I'll give everybody a second to write that down. Everybody got it? All right. So what about safety concerns for ocrelizumab? As I mentioned before, we always have to think about safety. And the way these new medications work in terms of controlling the immune system, that is important. Ocrelizumab does work by decreasing the number of what we call B cells. B cells are immune cells in your body, which also are involved in the development of multiple sclerosis. So far, the main concerns we've seen with safety in terms of using ocrelizumab have been infusion reactions. So this is typically during the patient's first infusion. They may have a rash, they may have some itching. The drug is being used with steroids. The steroids are given at the same time to try to reduce the side effects from the first infusion, but this does seem to be a pretty common reaction, not typically life-threatening, but can be somewhat of a nuisance when somebody's first getting the drug. This does have a tendency to improve over time, though. There's also, in general, an increased risk of infections in the rheumatoid arthritis trials. Remember, I told you that this drug is also being studied in a few other autoimmune diseases right now. And the rheumatoid arthritis patients have seen a few more infections, but this doesn't seem to be the case yet in the multiple sclerosis patients, at least in terms of serious infections. And that may be because the rheumatoid arthritis patients have been taking other medications that suppress the immune system. They may be sicker. There may be other differences between the rheumatoid arthritis patients and the MS patients. There's also, just to remind everybody, there is a theoretical risk of PML, which is called progressive multifocal leukoencephalopathy. This is a rare but very serious viral infection of the brain. Most people associate this infection with another drug called natalizumab or Tysabri, but it's important to remember that this drug is not exclusive to Tysabri and can theoretically occur in any medication that suppresses your immune system. A few cases have been seen in patients who took rituximab. Remember, I mentioned that rituximab is a drug that's very similar to ocrelizumab. So even though we haven't seen PML and ocrelizumab MS studies yet, this is something that patients need to be aware of. Okay. So, but either way, I think it looks really promising, and I think we're going to hear some good news about this drug in the next few years. So switching gears a little bit, I just told you about a study that we're getting ready to start. Now I'm going to tell you about a study that we just finished here not too long ago at U of M. This is another IV drug known as alemtuzumab. You may have heard of it in the names of either Campath or Lemtrada. Lemtrada is the new name for it for multiple sclerosis. And this is another IV treatment that is given fairly infrequently. It's actually only given once a year. Patients come in and they get this drug over several days' time, and then they go home and they're done for the year. This drug decreases not only the B lymphocytes or the B cells that I mentioned, like we did with ocrelizumab, but also the T cells. So these are immune cells, and they're called B and T cells, and we think these cells are involved in the formation of multiple sclerosis. This drug actually has a longer track record. It's already been used in leukemia patients for quite some time, so we do have some information from the leukemia patients as well. And we think that we're going to hear something about FDA approval for this medication soon. I'm sure that many of you, I did allude to this drug last year as well, that this drug was awarded fast track status by the FDA in June of 2010, so it's been 2 years, a little over 2 years. Fast track status is basically a process that the FDA gives certain drugs where they try to prioritize the review of these drugs in order to get it out on the market because of a significant clinical need. But I just want to remind everybody that fast track status does not necessarily mean fast. It just means faster than the normal process. So, and we're all eagerly awaiting their decision. But this drug also looks very effective, and it looks to be at least as effective as ocrelizumab across trials so far with the phase 2 studies. So in 2008, there were some phase 2 study results published for alemtuzumab. And what was done in this particular study, they tested 2 annual infusions of alemtuzumab. So patients came in, they got their first dose over a period of 5 days. Then they were done for the whole year. Then they came back and got a second dose over 3 days' time. And they were followed, and they were compared to patients who took Rebif. So again, comparing it to a drug that's already available. And it turned out that the alemtuzumab patients did much better than the Rebif-treated patients, both in terms of reducing the number of relapses that they had and also reducing the risk of disability progression. So patients that were in the alemtuzumab group had a lot less disability progression over those 2 years. And also the MRIs improved. So fewer lesions formed on the MRIs in the alemtuzumab group compared to the Rebif group. And interestingly, a few of the patients not only noticed that their disability progressed more slowly, but some of the disability that they already had improved based on a special exam called the Expanded Disability Status Scale, which is an exam we often use in clinical trials to monitor disability. So overall, this medication looked effective both for clinical reasons and for MRI. So based on the phase 2 study results, phase 3 studies were initiated, and they recently just completed. We have 13 patients here that went through the study, and they're now in an extension phase of the study where they're pretty much just followed for safety. But they overall have done very well. And even though we don't have published results from these phase 3 studies, those should be coming soon. This was a quote from the makers of alemtuzumab, that it showed superior efficacy of alemtuzumab compared with Rebif across multiple outcomes. And so far, they have seen superiority for alemtuzumab in terms of the relapses again, disability, progression, and of course improvement on the MRI activity. So pretty similar to what they saw in the phase 2 studies. But again, we're still waiting for that final publication, and based on this, hopefully FDA approval. So there are safety issues again. Anytime we're talking about suppressing the immune system with any medication, you have to think about safety. In terms of the alemtuzumab specifically, these were the main medical problems that were seen in both the phase 2 and the phase 3 studies. So a condition known as immune thrombocytopenic purpura, which is basically a problem with your platelets, where your platelets begin to decrease. Your body starts attacking them. Remember, we need our platelets in order to clot. So in the phase 2 studies, there were a few cases of this that went undetected because nobody knew that it was going to be a problem. And some patients had some serious, there were 6 patients that developed some serious consequences. But so far in the phase 3 studies, no serious consequences have developed from this because we've been watching for it, and we know to look for it now and treat it if we see it happening. There's another condition known as Goodpasture's disease, which is a kidney disease. This is very rare, but a few cases of it have been seen. Thyroid problems were actually fairly common with alemtuzumab, both hyperactive thyroid and hypoactive. So either the thyroid's working too much or it's not working enough. And in general, about 20% of patients across the phase 2 and phase 3 trials have had some sort of a thyroid problem, usually not serious, but something that might require medical attention. As I mentioned, increased infection risk, which you might expect given the fact that this medication does suppress the immune system to some extent. And then while the patients are receiving the infusions, many of them do develop a headache or a rash. So where is it going? Well, again, we're waiting an FDA decision, but the announcement could be as early as sometime next year. We're hoping that we'll hear something soon. But again, this and even the ocrelizumab, which I mentioned earlier, these are potent medications. They're fairly big guns, and so you want to make sure that you're always thinking about balancing the benefits and the risks if you do consider one of these meds. It may actually be best for patients who have failed another first-line treatment or another medication for their MS, given the fact that it is pretty powerful. You also have to remember that when these drugs are given, that they do decrease those immune counts for the long term. The drug only has to be given once a year because those immune cells that it decreases stay down for about a year. So it's important to remember that you can't turn the drug off once you've given it. Okay. So now I'm going to talk about another oral medication. There's a new drug called BG12, and the other name of this medication is called dimethyl fumarate. This drug has actually been available in several forms over the years. It was previously used, or still is used in Europe for the treatment of psoriasis, patients who have psoriasis, which is an autoimmune skin disease. And I've noticed that there have been several off-label versions of what we call fumaric acid esters that have been prescribed in Canada and also sort of outside of the United States. But this is exciting because this is an oral treatment that's taken 2 to 3 times a day, and it's being studied now in multiple sclerosis. And the makers of the company that this is being studied by the makers of Tysabri and Avonex, so Biogen. And it looks like from the clinical trials that we've seen so far that this drug may be doing a few things that we don't fully understand yet. Not only suppressing some of the inflammation or the immune reaction that happens with multiple sclerosis, but possibly also providing some protection to the neurons. So kind of an interesting mechanism. So far, there have been 2 big studies for BG12 in multiple sclerosis specifically. One of them was called the DEFINE study, and one of them was called the CONFIRM study, if anybody's interested. And it looks like, based on, these were both I should say that the DEFINE study was a study that just looked at BG12 compared to placebo, and the CONFIRM study looked at BG12 compared not only to placebo, but also to a drug called Copaxone. And in both studies, it looks like that BG12 reduces at least 50% of new relapses, which is great. There is some superiority over not only placebo, but possibly Copaxone as well, but these official study results have yet to be published, and we don't know yet if the superiority seen with Copaxone met the significance that they wanted it to. But so far, it does look like it is reducing the lesions at least, or the relapses at least by half, and it also was shown to reduce MRI activity and new lesion formation on MRI compared to placebo. So the nice thing about BG12 is because it is used to treat our psoriasis patients is that we do have a little bit more information about the drug's safety and side effects, which is always a concern when a new drug hits the market, is that you don't have a lot of information about the long-term effects. We do have a little bit more information about that now simply because it's been used in other diseases. So far, what people have noticed taking BG12, both in clinical trials and in psoriasis patients, is that this drug has a tendency to cause some flushing in a lot of patients, so redness and a warmth of the skin when they take it. It also may cause some gastrointestinal disturbances, nausea, diarrhea, abdominal pain have been seen. Nothing typically serious, but this could be problematic if a patient has a sensitive stomach. Rashes and allergic reactions were seen in some patients. This drug also has the potential to increase the white blood cell counts or the immune cell counts in the blood. And then finally, some mild changes in liver function, but again, these have not typically been serious. So overall, this looks like a pretty safe medication, but of course, these are side effects that you need to be aware of. So this drug was also awarded fast track status in February of 2012. Again, the company tells us that we're supposed to be hearing something about this soon, but that could still be a little while yet. Everyone currently is anticipating an FDA decision by next year, but that remains to be seen just based on what we've seen with alemtuzumab, I think. But this may be a suitable option for patients who have a difficult time tolerating the injections, who might not be quite ready for a stronger treatment such as alemtuzumab or ocrelizumab. So it's another option that may be coming very soon, and we're happy about that. So in general, I just wanted to sum up by saying that overall the future of MS I think looks very promising with these medications. I'd be happy if anybody wants to ask questions later about other meds that we didn't get to talk about, since just in the interest of time. But again, although there's no cure for MS, I do think that the recent advances that we have that we've made over the past few years have allowed us to control it better. Just remember that whenever we have all these new choices, we have to weigh the benefits against the risks, and it's going to involve active discussions with your doctor about which treatment is best for you. But I think this is very promising. So thank you all for listening.
Okay. So I'm David Irane. I'm also a faculty member here in the multiple sclerosis program at the University of Michigan. And I want to also take this opportunity to welcome all of you on the Saturday morning to our patient and caregiver conference. And I hope that you find it informative. What I'm going to do first, because I knew I would forget, so I made a slide. before I get in and talk about what I'm going to talk about, I want to call your attention to the 3x5 index cards that are in all of your registration packets. And the purpose of those cards, as Dr. Siegel alluded to when he spoke, is for you to write down questions that you might have. And we're going to have a panel discussion at the end of the formal presentations up here. And what I'm going to ask people to do is put a question down on an index card that you want us to try to address. And then I'm going to have you pass those cards to the center aisles after Dr. Maudreyer speaks, and we're going to collect them. And I'm going to go through them and organize them and collate them because some of the questions will be overlapping. And I have the privilege of moderating the panel discussion after Dr. Siegel speaks. So while he's talking, I'm going to organize the cards. And I'm going to just remind you that we're scheduled to finish at noon. So the panel discussion will be from 11:30 to noon. And we will try to get to as many questions as we can during that interval of time. But invariably, we can't answer them all. And I'll apologize in advance about that. But hope that you have good questions for us, and we look forward to an exchange of information in the context of our panel. So my title in the brochure was Nutrition in Multiple Sclerosis, and that's a pretty broad topic. It's also something that in 30 minutes I don't think I can do justice to. So as I was sitting down and thinking about what to talk about, I just went back to the things that I get commonly asked about by patients and family members in the clinic. And one of the subjects that comes up over and over again is, what can you tell me about the use of dietary supplements in multiple sclerosis? So that's really what I want to talk about today. So I'm going to spend a few minutes and just give you an overview about what dietary supplements are, and I'm going to highlight a couple of examples of common dietary supplements that many of you may be familiar with or even be taking, and what the medical evidence is that supports their use. So, first of all, a dietary supplement is any preparation. It can be a pill, it can be a capsule, a tablet, a liquid, a powder, any preparation that you take to supplement some specific component of your diet that may be deficient or lacking altogether. And it's important to remember that dietary supplements, while they are regulated by the federal government, they're not regulated as drugs. So they don't actually have to have Food and Drug Administration approval like some of the compounds that Dr. Braley was talking about. They're actually regulated as food products. There are guidelines that control what can be defined as a dietary supplement, and there was federal guidelines put out in 1994 about these compounds. So what am I talking about? So I'm talking about things like vitamins, minerals, herbal extracts, fatty acids, amino acids, or any sort of mixture or combination or extract of those things. And we'll get into talking about a couple of them this morning. So they're not actually defined as drugs per se. They're defined as food products. And so they don't carry the same restrictions that the Food and Drug Administration imposes on pharmaceutical preparations. But nevertheless, it's important to keep in mind that the companies that market these products cannot claim that their product treats or cures a particular disease. So that sort of claim is prohibited by the federal guidelines that I mentioned. So you should always be a little bit careful as you're reading about these things. Sometimes claims are made inappropriately about things. So just be a little bit cautious. They are, however, allowed to say that the preparation that they're marketing somehow supports the function or the structure of the body. So a good example is a compound called glucosamine, which is being touted as something that can support the health and well-being of the joints in the body. So the first dietary supplement that I want to spend some time talking about is vitamin D. And there's been a lot of interest and attention focused on vitamin D. And so I'd like to take a couple minutes and just refresh you about vitamin D. It's a substance that is ingested, and it comes in several different forms. So there's vitamin D2 and vitamin D3. But it also is a substance that's made endogenously within our bodies, and it comes from the compound cholesterol, which is a product of all the membranes of the cells in our body, and it gets converted into vitamin D through a process that involves exposure to UV irradiation, that is, by exposure to sunlight. So it's a fat-soluble vitamin, and it goes through a series of processes to convert it into the active form. And those processes take place in both the liver and the kidneys. So the active compound, which is 1,25-dihydroxyvitamin D, is not the same thing as what you either ingest in your diet or take as a supplement. It has to go through a set of chemical processes. Now, I did not mean for this to be a chemistry lesson, and so don't be dismayed. This is just a graphic representation of what I just said, that the biochemists who study vitamin D have taught us that the molecule goes through a set of steps in the body. So it can be derived from cholesterol, which is something in our body, and then exposed to UV irradiation in the skin and get converted into vitamin D. Okay? You can also take it in your diet. It gets absorbed through your intestinal tract, and it requires both the liver and the kidneys to get turned into its active form. Okay? So it's a set of biochemical reactions that takes place. So where did all this interest in vitamin D and multiple sclerosis come from? Well, there's been a lot of anecdotal evidence that's built up over the years that have tantalizingly linked the two. And the first piece of evidence was that people who were studying multiple sclerosis at a global population level began to notice that the incidence of MS was much higher in parts of the world that were further away from the equator. So as the latitude increased, going either north or south from the equator, the proportion of people that had MS living in those areas was a lot higher than it was than people who lived in tropical climates. And in fact, there was evidence to suggest that exposure to sunlight might actually protect against the development of MS. And since the biochemists had taught us that sunlight exposure was very important in converting vitamin D into its active form, the gears started to turn and people started to think about vitamin D in the context of MS. Dr. Siegel alluded to an animal model of multiple sclerosis that we use experimentally, and investigators were able to show that when you administered vitamin D preparations in this setting, it seemed to protect against the disease. And there were some anecdotal reports that vitamin D supplementation might reduce the risk of MS. So all these things over the last few decades really got a lot of interest going about this compound in multiple sclerosis. So this is an MS map of the world, and it's just to highlight the fact that as you go north from the equator or south from the equator, the proportion of people who have multiple sclerosis increases. So MS is very common in the northern parts of the United States, and it's very common in Canada. It's also very common in the Scandinavian countries, but by contrast, it's very uncommon in tropical regions. So we've known about this for a number of years, and the idea that sunlight exposure and perhaps vitamin D metabolism might be related to that has gained traction. So there was a study published in 2006 by a group of investigators at Harvard University that really sort of brought this information to the fore. And what they did was they got the smart idea that they were going to check vitamin D levels in a large population of young and otherwise healthy people. So they went to the United States military. So young people going into the military have to have a physical examination and get blood work done. And occasionally, every once in a while, one of those people goes on to develop MS. So they had a database of more than 7 million people who, that the military shared with them. They identified 148 people who had entered the military who went on to develop multiple sclerosis. And from that same group, they identified a very closely matched population of people who didn't go on to develop multiple sclerosis. And they wanted to compare them. Since they had blood samples saved from all these individuals, they were able to go back and measure the vitamin D levels in all of these samples. And then what they did was they divided both the patients and the healthy control patients into groups based on the vitamin D blood level. So they separated them into what are referred to as quintiles. So the lowest 20%, the next 20%, the next 20%, the next 20%, and then the highest 20%. And they asked what were the odds that you were going to develop multiple sclerosis based on which of these quintiles that you fell into. So this is a little hard to see, and I apologize. I pulled this right off. This study was published in the medical journal called JAMA, and I pulled this right off the JAMA website. So I'm going to talk you through it here a little bit. Bear with me, it's a little hard to see. So first of all, the effect that they observed was only in people who were of Caucasian background. It did not apply to people who were either African American or of Hispanic backgrounds, okay? And so what they've done here is they've separated both their control patients and their MS patients into the quintiles. So this is based on their blood levels of vitamin D. So the lowest group, the next 20%, the next 20%, the next 20%, and the highest 20%. And what this shows is the odds of developing multiple sclerosis seem to go down in the group that had the highest blood levels of vitamin D compared to the group that had the lowest level of vitamin D. So what these investigators concluded was that high circulating levels of vitamin D are associated with a lower risk of developing MS. So you were less likely to develop MS if you had higher blood levels of vitamin D. And so that really got a lot of people excited about the possibility that there was some connection between vitamin D and multiple sclerosis, at least in terms of the risk. So it was logical then to say, well, okay, if having high vitamin D levels protects you from getting multiple sclerosis, what would it do if you already have MS? So is there a benefit from taking supplemental vitamin D in patients with existing multiple sclerosis? You heard from Dr. Braley about the different phases of medical studies, and she mentioned that some of the studies are often comparing a drug against a placebo. They're done in a random manner, and patients are blinded, so they don't know whether they're taking an active drug or a placebo. So there actually are very few what we call double-blinded, placebo-controlled prospective studies of vitamin D in patients with existing multiple sclerosis. So I went in and looked in the medical literature as of a couple days ago. I could only find 12 prospective studies, and most of those studies were actually pretty small. They didn't have very many patients in it, so sometimes that makes you a little bit nervous about drawing conclusions. So there are a few studies, and few of them, even fewer, have actually looked at the effects of vitamin D as a additional treatment on top of existing therapy. So I don't think anyone would claim that vitamin D by itself is a way to treat MS, but the question is, if you're on treatment, say with an interferon medicine, if you also took vitamin D, would that provide additional benefit? But the few that have been done, and I'm going to highlight one for you and show you some results from that study, suggest that it can have some effect on the MRI scan. So this is the largest and most recent study looking at patients with MS who are on an interferon medicine, so one of our established treatments for MS, who then either were assigned to get additional vitamin D or a placebo. And they were followed prospectively and in a blinded manner. So that is to say, the patients didn't know which group they were assigned to, and the investigators who were following the patients were also blinded. So it was done in Scandinavia. So this is a group of Finnish investigators who undertook this study. So there were 66 patients in this study. So they were either assigned to take a placebo or they took 20,000 units of vitamin D per week. So that's roughly 3,000 units a day. And they came in at regular intervals for examinations over a period of a year. They had an MRI scan at the beginning of the study, and then they had an MRI scan at the end of the study, and those were compared. And the primary thing that the investigators were looking for was, did the taking vitamin D have an effect on the appearance of new lesions or active lesions on the MRI scan? And everybody was blinded. So this shows you that in those study groups, the people who were assigned to take vitamin D met one of the study criteria, that is to say that their blood levels of vitamin D went up with the treatment, and people who weren't on vitamin D, the blood levels didn't change over time. So it shows you that taking the dose that they were taking raised up the vitamin D levels to the range that they wanted to. Okay? There's a lot of information on this slide. Don't worry. The thing I want you to look at is this line right here. So it's the proportion of people that have these active hot spots on their MRI. That is, after the dye injection, the lesion turns brighter, suggesting it's an active lesion. And people taking vitamin D had fewer of these active lesions compared to people taking a placebo. And that was a very statistically significant difference. And this is just another way that the investigators analyzed the MRI scan. They used a computer to calculate the area of white spots on the MRI scan. And they showed that in both groups, the area did increase over a year's time, but it increased a lot less if you were taking vitamin D compared to if you were taking a placebo. Now, their groups were small enough, or they didn't follow them long enough to really show that that had a meaningful effect in terms of patients' clinical function. So this just shows you that the relapse rate and the walking times didn't seem to change when you took vitamin D compared to a placebo, but that's not to say it couldn't change if patients were followed longer or if the study included larger groups of patients. It just didn't reach the statistical significance that we'd like to see. But there was a trend that would suggest that vitamin D had some benefit. So the conclusions from this paper is that that taking vitamin D can supplement the benefit that that an interferon medicine already provides, at least to reduce the evidence of disease activity on the MRI scan. Now, is there too much of a good thing? And I want to caution people about vitamin D, because occasionally I'll encounter a patient who comes in to clinic and tells me about some massive dose of vitamin D that they're taking. And I want to just remind everyone that sometimes there's going to be too much of a good thing. So too much vitamin D in your system can lead to the level of calcium in your blood to increase. And high blood calcium levels can cause damage to your kidneys, to your bones, and to your soft tissues. So if you have hypercalcemia or high calcium levels, you have a variety of side effects from that: constipation, poor appetite, fatigue, irritability, and some GI symptoms like vomiting. So be careful. It's possible to take too much vitamin D, and it requires monitoring the blood levels of vitamin D and checking the blood calcium levels. So I don't want you to think that, boy, if I take, say, 2,000 or 3,000 units of vitamin D a day, it would be a lot better if I took 15 or 20,000 units a day. So that you have to be a little bit careful about that. And you should consult with your physician about that if you're taking vitamin D supplements. So when you go to see your doctor, they'll often ask you about what medications you're taking, and you might think about, well, what prescription medicines am I taking? But also remember to tell your doctor about other supplements that aren't being prescribed that you're also taking. So I want to turn my attention to fish oils and omega-3 fatty acids, because that's another hot button subject that I get asked about. So omega-3 fatty acids, or N3 fatty acids, are very abundant in marine species and plants. So flaxseed oil is a common source of these, and fish oils are a common source of these compounds. And there's many of them. There's not just one that is biologically active. So these are the names, the chemical names of some of the most common omega-3 fatty acids. And they came to light in the 1970s when investigators learned that populations in the Inuit people, the Eskimos, who had very, very high dietary intake of fish oils, had very, very low levels of cardiovascular disease. And people wanted to know why that was, and it became clear that the intake of fish oils could have a protective effect against heart disease, and there's been suggestions that they reduce cancer risk, they're beneficial if you have rheumatoid arthritis, and even some claims that they may protect against the development of Alzheimer's disease and dementia. So the question is, what are the benefits of these omega-3 fatty acids in multiple sclerosis? Well, rheumatoid arthritis is an inflammatory disease, and if it has anti-inflammatory properties there, maybe it would have anti-inflammatory properties in MS. And there was some small studies to suggest that that might be the case. Turns out that if you do surveys of people who have multiple sclerosis, it's been estimated up to a third of people have tried these. So it's proposed to be the most common form of what I'm calling a complementary or alternative treatment used in the MS population. So they're very commonly used, and the question then really is, are they beneficial? So, as clinicians, we want to give the best advice we can to our patients. Are there randomized, prospective, controlled studies to suggest that fish oil supplementation is useful in multiple sclerosis? So there's one study that's been published, actually, in this regard. It was also done in Scandinavia over a period of 4 years. Patients were randomized in a blinded manner to take fish oil supplementation in this form or a placebo for a period of 6 months. And so these patients all had relapsing remitting multiple sclerosis. They weren't on treatment, okay? And then after 6 months, then everybody was started on interferon treatment. And what they did was they looked at the MRI scan at the entry of the study and 6 months later, and then they followed the patients out for 24 months. And these are two figures directly from that study. This is the MRI, the proportion of patients developing new or active lesions on the MRI scan. And unfortunately, in this group, the appearance of new lesions seemed to actually be higher in the patients taking the omega-3 fatty acids compared to people taking the placebo. So that was disappointing. There wasn't an obvious effect of fish oil on the MRI scan in the absence of any treatment. And then at 6 months, as you remember, everyone went on therapy. And then if you followed them for 2 years, this is the proportion of people having a relapse over time of their multiple sclerosis. And you can see that the curves are identical here. So there was no statistical difference in the frequency of flare-ups or exacerbations of the MS, whether you're taking fish oil supplementation or not. So unfortunately, at this point, there's no beneficial effect of the omega-3 fatty acids on disease activity when it's used by itself in compared to a placebo. And furthermore, there's no clear benefit that it adds to the beneficial effects of interferon. And this study also showed that interferon by itself was very effective. We knew that already. So you have to be a little bit careful. I'm not saying that omega-3 fatty acids are bad. There's still a lot of interest in their use as protection against cardiovascular disease, but we have to use what the medical studies tell us to guide our patients. So dietary supplements, as I said earlier, are not pharmaceuticals that require FDA approval. They're regulated by federal guidelines as food products. You have to be a little bit careful about what kind of claims that the companies that market these supplements are making. It's not allowable to claim that they treat particular diseases. I think it's fair to say that dietary supplements are commonly used in patients with MS. So far, there's some interesting information to suggest that vitamin D supplementation reduces the risk of developing MS, or having a high vitamin D level reduces the risk of developing MS, or taking a supplement can add to the benefit that interferon medicine already provides. So far, there's no evidence that the fish oil supplements or the omega-3 fatty acids can slow the formation of new lesions on their own or augment the benefit of interferon. I think it's likely going to be studied further, but right now I just don't have medical evidence to suggest that it's beneficial. Okay, I think that was my last slide. So again, just to remind you, if you have questions about things that I've said, about what Dr. Braley has said, or what Dr. Maldreyer is going to talk about in a minute, put them down on your index card. I'm going to collect the cards and sort them after Dr. Maldreyer speaks, and we'll have the panel conversation after Dr. Siegel's presentation. So thank you very much.